Hi, today we're going to talk about the thyroid, and we'll be covering in one presentation hyperthyroidism and the other hypothyroidism. So a little bit about the thyroid. It's the largest endocrine gland. It's a butterfly-shaped organ located in the lower neck anterior to the trachea. It does consist of two lateral lobes, connected by an isthmus. The gland is about 5 centimeters long and 3 centimeters wide and only weighs about 30 grams. The blood flow through the thyroid is very high, approximately 5 times more than the blood flow through the liver. The thyroid gland produces 3 hormones: thyroxine, triiodothyronine, which is T3, thyroxine is T4, and then calcitonin. Various hormones and chemicals are responsible for normal thyroid function. Key ones among them are the thyroid hormone, calcitonin, and iodine. Now remember that iodine is essential for the synthesis of all these hormones. Iodine is ingested in our diet and absorbed into the blood through the GI tract. Secretion of T3 and T4 by the thyroid gland is controlled by the TSH, which is the thyroid stimulating hormone, also known as thyrotropin. The main function of thyroid hormone is to control cellular metabolic activity. Thyroid hormones affect virtually every major organ and tissue function, including basal metabolic rate, tissue thermogenesis, serum cholesterol levels, vascular resistance. Calcitonin is another important hormone secreted by that thyroid gland. It is secreted in response to high plasma levels of calcium, and it reduces the plasma levels of calcium by increasing its deposits into the bone. So the thyroid does a lot, right, guys? All right, so what is the prevalence of it in the United States? Well, about 12% are diagnosed with it, some type of thyroid. They estimate about 20 million Americans have some sort of thyroid disease. But you know what? Most people are unaware they even have a problem. Women are 5 to 8 times more likely to develop thyroid issues than men. What are the causes? It's relatively unknown. They don't know. Undiagnosed thyroid disease may put patients at risk for certain serious conditions like cardiovascular disease, osteoporosis, and infertility. Pregnant women with undiagnosed or inadequately treated hypothyroidism have an increased risk of miscarriage, preterm labor, and severe developmental problems in their children. Most thyroid conditions or diseases are lifelong conditions and have to be managed with medical attention. All right, so let's kind of talk about origins a little bit. You can either have primary or secondary issues. Now, primary just means that the disorder occurs when the problem is within the organ itself. So an example of that is the person has their thyroid removed, then they have a deficiency of thyroid hormone. Secondary is where the disorder is, primary organ is fine, but what happens is the stimulating hormone organ, like a pituitary, that pituitary gland has an issue and is causing problems. All right, so the first thing we're going to talk about is hyperthyroidism. This is the most common endocrine disorder. It is a form of thyrotoxicosis, resulting in excessive synthesis of secretion of those thyroid hormones by the thyroid. So there's too much thyroid hormones circulating through the body. Most common causes are Graves' disease, toxic multinodular goiter, or an adenoma. There are other causes include thyroiditis, which is an inflammation of the thyroid gland, or excessive ingestion of the thyroid hormone. So that can happen, right? Maybe they're taking too much of their medicine. Hyperthyroidism, like we talked about, is a sustained increase in the release of the thyroid hormone. Often occurs more often than women, right? And then we do see the highest frequency between the ages of 20 to 40 when it's diagnosed. Graves' disease, remember, is an autoimmune disorder that results in excessive output of thyroid hormones caused by abnormal stimulation of the thyroid gland by circulating immunoglobulins. It does affect women 8 times more than men. And like we mentioned, onset for Graves is usually between the ages of 20 to 30. The disorder may appear after an emotional shock, stress, or an infection, although we really don't know why that occurs that way, but that's primarily when it shows its head. All right, so what is our patient? What's going on? What are the symptoms? Usually the most common presenting symptom is nervousness, but often emotional hyperexcitability, irritable apprehension, can't sit still, sit quietly. They may complain of palpitations. They may say that their pulse feels like it's too fast when they're sitting down and resting. They tolerate heat poorly. They perspire usually. Skin is flushed continuously. People that are Caucasians tend to may have a salmon color to their skin. Skin is warm, soft, and moist, but they also may report dry skin and diffuse pruritus. You may see a fine tremor in the hands, and patients may exhibit ophthalmopathy, which means problems with the eyes. They have some type of abnormal eye appearance. Okay, and I have a picture of that in a minute. I'll show you that. An example of it is the exophthalmos, where the eyes are kind of bulging out. And when they have that, they have not only the eyes protruding, but they kind of have like a startled look on their face. Now, when our patients have those kind of problems, sometimes they don't go away even with treatment. So we do need to discuss with them, and then you're going to be dealing with the whole body image kind of thing. Okay? They may have increased appetite and dietary intake, but then they have weight loss. Even though they're eating a lot, weight loss. They have fatigue, weakness. They might have difficulty getting up from a chair. Women may experience amenorrhea, changes in the bowel habits. Atrial fibrillation can occur in about 15% of the population that develops this. Also, sinus tachycardia is common. All right, so here's an example of some symptoms. This is what I was talking about, the bulging of the eyes, the exophthalmos, when they have eye issues. They kind of look like they've just been startled, scared, right? Then here is an example of a goiter, where you see the thyroid gland is enlarged, and you can actually, remember in assessment when you were assessing to palpate the thyroid, and normally you shouldn't palpate it, right? Well, here you would feel an enlarged thyroid here, and you could also, if you place your stethoscope over it, you might even hear a bruit over the thyroid. All right, so here's a cute little cartoon about hyperthyroidism. Other symptoms that you might see. Sometimes these visuals just help with everything, right? I love Pinterest for this kind of stuff. So how are we going to diagnose the patient? Well, we're going to get a good history, physical exam. They will need an eye exam, especially if they're having eye issues. EKG, because we want to see, are they in atrial fib, sinus tach, what's going on? They're going to have a radioactive iodine uptake study. They'll also have blood tests. TSH, T4, T3, T4 are all going to be drawn. Treatment, what are the goals? Well, the goals are to block the adverse effects of what's going on, right? So this could happen with a combination depending on what the underlying issue is. It could be, they could hit them with antithyroid agents, radioactive iodine, and surgery. Treatment is usually directed towards reducing the thyroid hyperactivity to relieve the symptoms and prevent complications. The use of radioactive iodine is the most common form for treatment for Graves' disease in North America. Beta-adrenic blockers like propranolol, atenolol, or metropol are used as additional therapy for symptomatic relief, for those heart palpitations. Surgical removal of the entire thyroid gland or part of it is an alternative treatment. All three treatments share complications: relapse of recurrent hyperthyroidism, permanent hypothyroidism. Rate of relapse will increase if the patient had severe disease, so if they really were full-blown major disease. If they relapse after radioactive iodine therapy, it may have to do with the dose that was used in the treatment, so they may have to have a different dosing. As far as medications go, two forms of pharmacotherapy are available for treating hyperthyroidism. The use of irradiation by administration of a radioisotope, 1, for destruction of the effects of the thyroid gland. Remember, if they're going to have this, they must have a pregnancy test before, and they have to be on some form of birth control to prevent pregnancy for at least 6 months after treatment. Over several weeks, this radioisotope iodine dissipates the thyroid and eventually puts the person in a hypothyroid state. Some patients are at high risk for complications of hyperthyroidism and may need pre-treatment with an antithyroid medication prior. This population that would be at risk would be like the older adult, someone with cardiovascular disease. They're going to get this drug called methimazole, or otherwise known as MMI. This is given about 4 to 6 weeks prior to administration of the radioactive iodine. This medication will be stopped 3 days prior and restarted 3 days after administering the radioactive iodine, and then is tapered over a period of 4 to 6 weeks. It initially causes an acute release of the thyroid hormone from the thyroid gland and may increase symptoms. So we have to observe the patient for thyroid storm, because this is a life-threatening condition manifested by cardiac dysrhythmias, fever, and neurological involvement. Lots of times patients, again, in this situation will be also placed on beta blockers. So thyroid hormone replacement is going to be needed. If we're knocking out the thyroid, right, we have to still have some thyroid hormone in our system. So thyroid hormone replacement is usually started about 4 to 8 weeks after antithyroid medication has been stopped, based on the results of their thyroid function studies. Alright, so let's talk a little bit about thyroid storm. This is a form of severe hyperthyroidism, usually abrupt in onset. Untreated, it's almost always fatal. But with proper treatment, the mortality rate is reduced substantially. The patient with thyroid storm or crisis is critically ill and requires acute observation, aggressive and supportive nursing care during and after the acute stage of the illness. What are the clinical manifestations? Well, high fever, greater than 101.3. Extreme tachycardia. You're talking about heart rates greater than 130. Exaggerated symptoms of hyperthyroidism with disturbances of major systems. GI, you're going to see weight loss, diarrhea, abdominal pain. Cardiovascular, you're going to see edema, chest pain, dyspnea, palpitations. You're also going to see the patient experience also neurological or mental status. They may even appear delirious, psychosis, or even develop a coma. Life-threatening thyroid storm is usually precipitated by stress, such as an injury, infection, thyroid and non-thyroid surgery, tooth extraction, insulin reaction, diabetic ketoacidosis, pregnancy, digitalis intoxication, abrupt withdrawal of antithyroid medication, extreme emotional stress, or vigorous palpation of the thyroid. These factors can precipitate the thyroid storm in the partially controlled or completely untreated patient with hyperthyroidism. We do see less and less of thyroid storm now because people are being treated more effectively. Management, the immediate objectives if a patient has thyroid storm would be to reduce body temperature, heart rate, and prevention of vascular collapse. So how are we going to lower the temperature? Cooling blankets, hydrocortisone, Tylenol, aspirin, those kind of things. Going to place it on humidified oxygen to improve tissue oxygenation and meet their high metabolic need demands. Patient will have arterial blood gases drawn and continuous pulse oximetry. IV fluids containing dextrose are administered to replace liver glycogen stores that have been decreased in the patient who is hyperthyroid. PTU is administered to impede the formation of thyroid hormone and block the conversion of T4 to T3. Hydrocortisone is prescribed to treat shock or adrenal insufficiency. Iodine is administered to decrease the output of T4 from the thyroid gland. For cardiac problems such as atrial fibrillation, dysrhythmias, and heart failure, you're going to give them medications to control those areas. Lots of times we're going to give them some propranolol combined with digitalis to help with severe cardiac symptoms. All right, so patient decides to have surgery and have the thyroid removed. So it is the main method of treating hyperthyroidism. Today, actually, to be honest, it was once the main effort, I meant to say. And you're seeing it less and less now. So usually surgery is reserved for special circumstances. For example, if the patient's pregnant, a pregnant woman who has an allergic reaction to the anti-thyroid medication, patients with a really large goiter, and patients for whatever reason are unable to take anti-thyroid medications. Surgery for the treatment of hyperthyroidism is performed soon after the thyroid function has returned to normal. So surgery usually remove about 5/6 of the thyroid tissue. It's called a subtotal thyroidectomy. They find that has reliable results, and they have prolonged remission. Before surgery, an anti-thyroid medication is given until hyperthyroidism symptoms disappear. A beta-adrenergic blocker like propranolol will be used to reduce heart rate and other symptoms of hyperthyroidism. Medications that may prolong clotting, like aspirin, are stopped several weeks before surgery to reduce the risk of postoperative bleeding. Patients receiving iodine medication must be monitored for evidence of iodine toxicity, which requires immediate withdrawal of the medications. Symptoms of iodinism include swelling of the buccal mucosa, excessive salivation, cold symptoms, and skin eruptions. The incidence of relapse with a total thyroidectomy is nearly 0%, whereas the recurrence with a subtotal thyroidectomy is about 8% at the 5-year mark. So our patients had surgery. What are we going to do for them? Well, you have to do the general post-op stuff. Leg exercises, coughing, and deep breathing. I'm going to prevent clots, prevent atelectasis, right? Still got to do that stuff. But because they've had surgery in the neck area, we do have to support the head when turning in bed. We're going to do some range of motion exercises for that neck. And we do know that they may have trouble speaking initially after surgery. The other things is, you're increasing diet, fluids, monitoring vitals, controlling pain. We have to watch to make sure that The parathyroids have not been involved. Okay? What are you going to assess for? What do the parathyroids do? You're going to make sure that you check for you're going to check calcium levels and look for symptoms of hypercalcemia. Remember, this surgery, because it is in the neck area, could lead to vocal cord paralysis as well as airway obstruction. So you want to make sure that you're assessing for that continuously. Initially, when they first come up, you're checking them at least every 2 hours, if not more frequently, for signs of hemorrhage, as well as tracheal compression. Tracheal compression symptoms could be irregular breathing, neck swelling, frequent swallowing, choking. They should be in a semi-Fowler's position, and you should have no tension on those suture lines. So their neck should be kind of relaxed and not, extended back. Would be an example of what you don't want to see. Okay? Remember that they may have some hoarseness. That's okay. But if we know that they're frequently swallowing, that could be a sign of airway obstruction, that there's things going on inside that we can't see, that they're starting to get the airways narrowing because of inflammation. So we definitely want to keep very close eyes. The other thing is hemorrhage. Remember, this is an organ that a lot of blood went through, right? So we want to make sure that we are checking for that. Key points to check for that is not just the dressing anteriorly, but we want to check the neck posteriorly as well. Because the blood could have pooled to the back of the neck. All right, here's a question for you. When assessing a patient who has returned to surgery after a thyroidectomy, the nurse would be most concerned with? Which one would you be most concerned with? And remember, think airway. Remember ABCs. And if you chose 4, you're right. Because remember, making those harsh sounds, that could sign of airway obstruction, right? Harsh vibratory sounds. That airway is narrowing. Okay, so what are potential nursing diagnoses, or what are our goals here for our patient? Potential nursing diagnosis for the patients could be risk for injury, imbalanced nutrition, anxiety, insomnia. So the goals for our patient may be to improve nutritional status, improve coping, improve self-esteem, maintenance of normal body temperature, and absence of complications. So think about improving nutritional status. What are you going to do? Since we know it affects the GI system, the appetite has been increased. It may be satisfied by several well-balanced meals in small size, even up to 6 meals a day. Food and fluids are selected to replace fluid loss through diarrhea and diaphoresis, and to control the diarrhea, so increasing the fiber. We want to avoid further weight loss. So to reduce diarrhea, one thing we might do is discourage teas, colas, alcohol, highly seasoned foods, stimulants, that kind of stuff, coffee. High calorie, high proteins food should be encouraged. A quiet atmosphere during mealtime to aid in digestion. And then we should have them monitoring their weight, probably almost on a daily basis. For improving coping or enhancing coping mechanisms, these patients need reassurance because their emotional reactions are different than what they're used to, right? They're not used to this stuff, so you want to make sure that you're there for them and listening to them as well. It's important to use calm, unhurried approach to these patients. Also discuss, their friends may think like they're gone insane because they're just so irritable and like snapping at them kind of thing. So we want to talk to them about that kind of stuff as well. Encourage relaxing activities, things that don't overstimulate them. They need to balance periods of activity and rest as well. If a thyroidectomy is planned, the patient needs to know about pharmacological therapy that's necessary to prepare the thyroid gland for surgery. The nurse should provide education regarding any type of medications the patient's going to be on. And we have to be careful because remember they're in this hyperexcitability state. They have a decreased attention span. So we definitely might have to repeat things over and over again in any part of our teaching process for these patients. Improving self-esteem. Remember, body image, right? Changes. Those eyes bulging out kind of freak them out. So we need to talk with them about that. As well as the patient and family need to be reassured that a lot of these changes are a result of the thyroid dysfunction. And in fact, once it's controlled, most of them will go away. But some might. You know, like we mentioned, the eye thing might not go away. So they need to be aware of that as well. They should not, if they are a smoker, they should stop smoking. As far as body temperature, the patient with hyperthyroidism frequently finds the normal room temperature too warm because of their increase in metabolic rate and increase in heat production. So we want to maintain an environment that's cool, comfortable. We may encourage cool baths, drinking of cold fluids to provide relief. As far as managing and monitoring for potential complications, we're looking always for patients with hyperthyroidism for signs and symptoms indicative of thyroid storm. We're watching their cardiac and respiratory status, monitoring vital signs, cardiac output, EKGs, monitoring. Arterial blood gases and pulse oximetry are all good to do. Assessment continues after treatment and initially because of potential effects of the treatment on the cardiac function. Oxygen is used to prevent hypoxia. IV fluids may be necessary to maintain blood glucose levels and to replace lost fluids. And then if they have cardiac symptoms, we may as well be placing them on beta blockers, like we mentioned earlier. Going to provide education. Remember that, you know, they're going to be on medication for the rest of their lives because of this. They need to be aware of symptoms. They may have initially blood work that's going to be ordered pretty frequently initially. And then just follow-up care for their incision. They, you know, if we're getting ready for discharge, what can they, you know, is there weight limitations, lifting? Is there certain activities at home that they can't do? If they are a person that exercises, when can they go back to exercising? You know, just those general post-op care questions.